question. A 42-year-old Caucasian woman presents to the OP when she is 10 weeks pregnant with her second baby. Her first pregnancy was complicated by peripartum cardiomyopathy with moderate impairment of left ventricular ejection fraction. However, she did not have complete resolution of systolic function 6 months after the birth of her first child. Which one of the following statements is true? So what is this? The patient, a 42-year-old lady, she has come to the OP. She is now 10 weeks pregnant with her second baby. Her first pregnancy, she had peripartum cardiomyopathy, which actually had moderate impairment in left ventricular ejection fraction. She completely had resolution of the symptoms after that, within the 6 months after the birth of her child. Which of the following statements is true? So before we go into the options, we'll discuss something a little bit about peripartum cardiomyopathy. I have not discussed it in the previous topic, so I have just mentioned it in the previous chapters, but I would like to discuss some points in detail which you must remember for your MCQs. Okay, so what is peripartum cardiomyopathy? How do you actually define peripartum cardiomyopathy? First, let us define peripartum cardiomyopathy. Peripartum cardiomyopathy. How would you define that? So, it is something that happens. It's a cardiomyopathy which happens towards the end of pregnancy. Towards end of pregnancy, or within 5 to 6 months post-delivery. 5 to 6 months post-delivery. Okay, it can happen either during pregnancy or immediately after delivery. So when this happens, it's called peripartum cardiomyopathy. So what happens in these patients? The ejection fraction will be less than 45%. The ejection fraction will be less. Okay. And what else will they have? When do you suspect the patient's age will be more than 30 years? The patient's age will be more than 30 years. The risk factors are the patient will have more age, the age of pregnancy will be more, gestational age will be more. Then they may have some other comorbidities like an existing heart issue, or they can have multiple pregnancies. Okay, so if it's a twin or a triplet pregnancies, or even 4 quadruplets, which is now very common because of this in vitro fertilization. Okay, multiple pregnancies. Okay, then diabetes mellitus, then cocaine abuse in the mother. Cocaine abuse in the mother. All these are very, very important risk factors for a patient to develop cardiomyopathy. Okay, the other risk factors which will be preeclampsia and eclampsia, all hypertension, all these are very, very important. Diabetes, all these even communicable diseases which happen in the pregnant mother are also contributing to peripartum cardiomyopathy. So how do we define it? Peripartum cardiomyopathy is cardiomyopathy happening towards the end of pregnancy or between 5 to 6 months post-delivery. The ejection fraction will be reduced less than 45%. And the risk factors include patients more than 30 years of age, multiple pregnancies, the patient will having diabetes mellitus, preeclampsia, eclampsia, then maternal cocaine abuse. All these are very, very important, risk factors. So what actually happens in these patients, in whom is it most common? It is most common first in Africans. Africans is most common. Second will be Asians. Asians, it is also common. So Africans, it is most common. It is very, very characteristically seen in Africans. In Asians, it is second most common. Okay. Yes. So there is some hormonal changes, some vascular changes will happen, which contribute to the patient developing peripartum cardiomyopathy. What are these? These are hormonal changes, the involvement of the RAS system, then also including some vascular changes which happen, which contribute to the development of peripartum cardiomyopathy. Okay, so what happens? How do you treat this patient with cardiomyopathy? All of you know the treatment will be the same. So for acute cases, what do you do? Treatment for acute cases, you give the patient oxygen, you give symptomatic relief, you give mechanical ventilatory support if the patient requires ventilation, mechanical ventilator support. And the drug that you must remember in this patient is bromocriptine. Yes, bromocriptine. Bromocriptine. So bromocriptine is used in the treatment of acute peripartum cardiomyopathy. Peripartum cardiomyopathy, bromocriptine is very, very important. This can be an MCQ question. So how do you treat chronic peripartum cardiomyopathy? How do you treat? So you use RAS blockers. What do you use? RAS blockers, then beta blockers. RAS blockers, beta blockers, etc. Okay. And you may also need a cardioverter defibrillator in these patients if they are having rhythm abnormalities also. So, and they actually predisposed to rhythm abnormalities. So you might also actually need a implantable cardioverter defibrillator. Okay, so RAS blockers and beta blockers are very, very important. So I would like, including all this, you must also know about the prognosis, because most of the questions and the question that we have also discussed is based on the prognosis in these patients. How do you prognosticate the patient? So a patient comes to you and asks you, what is the risk of me developing peripartum cardiomyopathy next pregnancy also? What will you answer? So for that, you need to know about the prognosis, right? So how do you define the prognosis? This prognosis is generally good in all the patients. They actually have complete resolution of symptoms. Like in this question also, the first time around, she actually had a complete resolution of her symptoms, right? So the prognosis is good. Okay. So what happens? In this, almost 50% recover completely. The 50% will recover completely. Then 20% among that will have relapses. 20% will have relapse of peripartum cardiomyopathy. This is very, very important. 20% will have a relapse. 50% will have completely cured, will be completely cured, whereas 20% will have a relapse. Okay. 25% will have persistent symptoms. Okay. They will not have been completely cured, but they will have persistent symptoms. Okay. They will have persistent symptoms. And 25% will develop complications. They will not be able to come out of the ventilator. They may have arrhythmias. Okay. So they may go into development, they may go into complications. Or less than 10% will have mortality. Okay. Less than 10% is the mortality. So it is very, very less. Just around 3% will be the mortality. So this is very, very important. The prognosis is very good. 50% almost have complete resolution of symptoms and 20% will relapse. Okay. So in this question, so what are the options? A risk of death during pregnancy significantly increased. No, we saw that the prognosis is good. The mortality is very, very less. A risk of developing heart failure during pregnancy is around 20%. Okay, we'll come to this option. If she develops cardiomyopathy during this pregnancy, the likelihood of resolution of LV function after pregnancy is high. Yes, because it's a recurrent episode, the resolution of symptoms may not be complete. Okay, so this is also not correct. Prophylactic use of ACE inhibitors is mandatory. We cannot prophylactically use because ACE inhibitors are contraindicated in pregnancy, right? So in pregnancy, you cannot use it. Post-delivery, you can probably use it, but in pregnancy, you cannot use. So prophylactic use of ACE inhibitors is not recommended. Early detection of heart failure by clinical examination during the pregnancy will be sufficiently sensitive to detect deteriorating LV function. So during a pregnancy alone will not be sufficient. You need to have a watch out in the postpartum period also. Okay. After the delivery of the baby also, you need to be cautious. So it is not only during pregnancy. So the correct option will be a risk of developing heart failure during this pregnancy is 20%. Why is it? Why do we say about this golden number 20%? I told you that is the relapse rate. Relapse rate. So you remember, it's because her first pregnancy, she had a peripartum cardiomyopathy. This is the second time around. And so she has a relapse of around 20%. So this is the answer for this question. Okay. Yes. You have been referred